Good morning, everyone. I'm Diane Cohen with MacroPro, and I'm joined by April McDonald. April, how are you today?
I'm doing great. I'm just happy to be here.
Oh, wonderful. I want to thank you so much for helping us get today's speaker. Can you tell people who you are, who you work for, what you do?
I am April MacDonald, and I work for Platinum Reporters and Interpreters. Basically, we do court reporting and interpreting. I'm the VP of Business Development, and I basically go out, get business, and help implement it. And then I'm a liaison between adjuster, employer, and attorney.
Got it. Well, we're doing the summer school series in order to help examiners catch up on their hours before they have to report on July 1st. But I see you look like you have a summer school going on right behind you. What's going on?
So my daughter, her friend, and I, we ordered one of those paint and sips where you can watch a video online. So we started making them their little sloths. So we have to finish up. We'll have a daisy crown. So we're doing our own little paint and sip. We got two different kinds, and so we decided to do the sloth, and they're coming
Oh,
out
that's
okay.
That sounds like fun. I think that's a really fun summer activity, and you can do it at home. I didn't know you could do those at home.
And you could
Um,
pause it so you could catch up. That's the good part.
that would be really important for those of us who don't paint. Well, April, I'm going to go ahead and let you introduce Doctor, or at least explain to everybody how you met Doctor, and thank you for bringing him on today.
Okay, so I met Dr. Ron Heredia back in when they still had the Dana Point conference, and he was speaking, and I went into the actual session, and I heard him speak, and it was the first time I ever heard him speak or met him, and he was so great. He is fantastic, and we hit it off. We went to dinner that night, but I have him now do all my speaking engagements. I'm like, are you busy? What are you doing? So here is Dr. Ron Heredia.
Well, thank you, April, for the very kind introduction. Great to have met you so many years ago as well. And thank you, Diane, for allowing us to be here and to share this wonderful information with you all. I appreciate everyone on the call today. Thanks for joining. My name is Dr. Ron Heredia. I'm here to share with you information about pitfalls in telemedicine psych evaluations and reports. There is a QR code on the screen. You'll notice this will appear a couple of times throughout the slides, meant for you to scan if you wish to participate in some fun questions and answer type scenarios that'll appear throughout the slideshow. Without further ado, let's go ahead and begin. And I'll introduce myself just a bit further so you get to know who I am a little bit more and why I'm here delivering this information to you about telemedicine in psych reports and evaluations and the pitfalls that we should all be aware of. I'll go through what should be in psych reports for those of you who handle psych claims and receive reports from treating doctors and evaluating physicians. I'll discuss some of the major pitfalls that you should be concerned with and be able to pick up on your own as you're reading psych reports written by psych doctors and LCSWs, licensed clinical social workers, who can also do psychological treatment in work comp. Throughout the session, I'll give some tips and strategy for questions attorneys might want to consider using in deposing psych doctors who use telemedicine. And I'll also discuss the significance of considering consultation reports when challenging or rebutting psych reports, especially those that are done via telehealth or remote methods. Again, I'm Dr. Ron Heredia. I'm the director of Good Mood Legal. We are a psychology consulting practice where there's a team of psych PQMEs. And one of the hats that I wear in the practice is evaluating and critiquing psych reports, helping examiners, employers, and attorneys rebut or challenge psych claims and psych doctors' reports when warranted. I'm also a professor of psychology at the college level. I teach a variety of courses, and one of the parallels that I've been able to identify between my work at the college and my work with folks like you all in the work comp space is psychological testing. That is a parallel that exists. My students have lots of questions. They usually know nothing about psychological testing. And of course, in workers' compensation, psychological evaluations and treatment, psych testing is a major component and is a part of every psych report that we should be concerned with. And I will also discuss psych testing today as we view psychological testing through the lens of telemedicine. And I hope that you bring your questions for me throughout the session. I do welcome that. I'll also have time at the end of today's session for any questions or answers or concerns with some of the information that we bring up here today. I'd like to begin our discussion with substantial medical evidence. What is that term? We hear the term substantial medical evidence very often in work comp. And as far as psych evaluations and reports is concerned, substantial medical evidence means that there is a diagnosis, a psychological disorder given by a evaluator or treater, and there must be support or evidence for that diagnosis to be correct. That is the substantial medical evidence. So a report can constitute substantial medical evidence if it has the relevant and necessary data or support in the report to support the doctor's diagnosis. Excuse me. And I'll discuss how we can determine whether a report constitutes substantial medical evidence, especially when the psychological evaluation or treatment is done via telehealth or telemedicine. So that's a major factor introduced in telehealth evaluations or methods. A psychological disorder comes from the DSM. The DSM stands for Diagnostic and Statistical Manual of Mental Disorders. I have some images here on the screen for you just to see what the book looks like. These are the manuals, so-called Bible of Psychology. And the manuals are nicknamed the Bible of Psychology because every psychological disorder that exists and is real must be in this manual. If the psychological disorder is not in this manual that is published by the American Psychiatric Association, then it's not a psychological disorder. And the entire world uses the American Psychiatric Association's DSM. Every disorder lives in this book. And in the book, if you've ever opened one, you'll find a psychological disorder followed by the criteria that an individual must meet in order to have that disorder correctly given. And so it's important that we go through a psych doctor's report and determine if there's enough evidence or data in that report that matches the disorder as it exists in this book. You can do something very similar to what I do when I receive psych reports from examiners, attorneys, employers. They usually will email me a psych report saying something like, I have this report, it's a high exposure case, please help. And so what I do, first things first, I take the report, I put it on my desk, side by side with the DSM manual that the doctor used. There are various manuals that they can use, or versions of it, I should say. You see the DSM-4 TR in silver. That was published in the year 2000. You see the DSM-5 in purple, published in the year 2013. And then the most recent manual, the DSM-5 TR, TR stands for text revision. That was published in March 2022. Whichever version the doctor used, I put it on my desk and I open up to the page that has the disorder that the doctor gave. For the purpose of this discussion, I'll go with a major depressive disorder, and oftentimes maybe the secondary disorder being generalized anxiety disorder. So I'll use those as an example as I discuss telehealth and the pitfalls in psychological evaluations and treatment. First, we consider the 5 areas where a doctor can possibly put in their report the data or evidence to support their diagnosis of, let's say, a major depressive disorder. The 5 sections of the doctor's report that you and I should be concerned with are the patient's life history and their presenting complaints. That's first. That's the section of the doctor's report you can turn to, and you can find where the doctor is going to talk about where the patient lives, who their family is, where they've worked. There's also usually a section in there dedicated to discussing the injured worker's symptoms or complaints, those are synonyms, on the day of the exam. That's important to find. The next section is the doctor's report of their mental status examination results. The next section we should look at is the psychological testing data. And then there can be a review and discussion of the patient's medical records and a discussion by the doctor of collateral sources of information. That is, if the doctor finds it necessary to interview the injured worker's family, friends, or coworkers. This is a very rare situation. Typically, will only be needed if the injured worker cannot speak or think for themselves. Perhaps they're a victim of a stroke, they have extreme paranoia or hallucinations, they have laryngitis, they stutter, something to that effect, or they cannot speak or think for themselves. Perhaps they're deceased, then the doctor would want to interview the family, the friends, or the coworkers. Before we look at, I'm going to back up here. We're going to go through the top 3 in green font here, because these are the most significant sections of a doctor's psych report. When they do a telehealth examination or remote evaluation, it's especially concerning because there are so many pitfalls. So I'll guide us in this discussion through the top 3 sections and discuss some of the pitfalls in telehealth evaluations that you'll find in these 3 sections of the doctor's report. Before we do that, I want to pay special spotlight on this figure. The psych diagnosis vulnerability model is what I've developed and call this model. And it illustrates for us exactly the layout of a psych report and the doctor's opinions. And so I'll explain. On the bottom, you have a triangle, which is the report, the doctor's report. That's the report or the evidence that the doctor submits to you all, to the attorneys, to the court, to the parties involved in the case. In that report, we will find many opinions. The first and foremost opinion, the primary opinion, is the diagnosis, because Labor Code section 208.3 says, in order for there to be a compensable psychiatric injury, there must be a psychological diagnosis given by the psych doctor. So we have that diagnosis, and that diagnosis carries with it the balloons, is what I call it. The balloons of causation, gaffe, disability, apportionment, and treatment. Excuse me. The opinions of causation, gaffe, disability, apportionment, and treatment will go away with the psych diagnosis. If the psychological diagnosis is discredited, nullified, thrown out, then it takes with it causation, gaffe, disability, apportionment, and treatment. Those opinions will fall by the wayside. We don't have to worry about them, and there will be no compensable psychiatric injury. So for that reason, it is my strongest recommendation when challenging or rebutting a psych report to challenge the doctor's diagnosis, rebut the diagnosis, nullify, discredit, attack, however you want to say it, that diagnosis. That is the focus, because the doctors, in my 25 years of experience in the work comp space, reading psych reports written by other psych doctors, 25 years, I read psych reports from other psych doctors every day. And it is a rare occasion that I have ever read a psych report in California work comp from a psych doctor where the diagnosis is supported with substantial medical evidence. To say that another way, almost every psych report in our state work comp system, unfortunately for the colleagues in my field, they're not, those psych diagnoses are not supported by what you find in the doctor's report. And so I'm going to guide us through finding that information and identifying that the report doesn't constitute substantial medical evidence, and an attorney should go in and depose the doctor to expose that the diagnosis is unsupported and discredit that diagnosis. And then, voila, no compensable psychiatric injury. So I'll demonstrate how this can be done and what you all can pick up for and identify in the reports for yourselves. It's also my strongest recommendation for attorneys when I give this talk to attorneys, and if there are any attorneys on the call, during deposition, question the report only. Don't question the doctor's memory or thoughts about the injured worker, only question their report. Example, do not ask questions in a deposition setting that sound like this. Doctor, you said the patient was depressed. Can you tell me about their depression on the day of your exam? Don't ask a question like that. That would allow the doctor at that point to say anything they want and get that evidence into the deposition transcript. Instead, ask a question that sounds like this. Doctor, you said that the patient was depressed. Where in your report can I find where you discussed the frequency of the patient's depression or how often they feel depressed? Where in your report can I find the duration of the injured worker's depression? Or when they had that depression, how long did it last? What's the duration? Ask questions about the report only. The report is the doctor's evidence that they submitted to the court. The report is what the doctor gets to bill for, not their memory of the patient, not their notes in their filing cabinet, only the report. So here is going to, our next slide will appear our first question, interactive question. So I encourage you all, if you haven't done so already, to scan and participate in this live question answer session. And I'll go through and that QR code again appears in this corner of the screen. The question is, for us all, what psychological diagnosis do you see most often diagnosed by psych doctors? In the reports that you've handled, the psych claims that you've worked on, what psychological diagnosis do you see most often diagnosed by psych doctors? What are the psych diagnoses that we see in reports? Give it a few more seconds for folks to participate. And thank you for those who are actively answering on the app or on the QR code. And you might remember that early on in our discussion today, I mentioned that for the purpose of this discussion, we would use major depressive disorder as an example and or generalized anxiety disorder. And as we can see on the screen here, many of you folks on this call have seen major depression as the disorder that you often see diagnosed by psych doctors. So great, thank you so much. We also see adjustment disorder is a big one that we see. Now, it's always different when I give this similar presentation to folks who handle public entity, employers, police officers, firefighters, cities. I often see that the bar graph is highlighted most for post-traumatic stress disorder. And of course it varies depending on the employer and the type of injuries that might occur. Major depressive disorder. So thank you for that participation. This slide brings us to area number 1, if you remember the green font areas, the 5 of them, right? I only had 3 that were in green font. This is the first of those 3. This is a section of every psych report that you can find after you flip to the back and you try to find where the doctor provided their psychological diagnosis, and you perhaps will see a major depressive disorder there, or an adjustment disorder, or both. The next step is turn to the section of the doctor's report where they discuss the patient's life history and presenting complaints. Every report must have a complete history of symptoms or complaints. But guess what? Most every report lacks a complete history of symptoms or complaints. I'll explain. When I turn to this section of a psych report, all I ever read is a section that sounds like this. In 25 years, most psych reports that I read, the doctor states something to the effect of, the patient complained about being depressed and anxious. They said that they have pain in multiple areas of their body. The injured worker discussed sleep difficulty and concentration difficulty. They also said they forget where they put their keys on a daily basis. That's it. That's how the doctors stated in their report for the most part. And that way of explaining the symptoms or complaints is all wrong. It's not complete. It is actually incomplete in every way. I put FIDO-C as an acronym on the screen here for you. A complete history of symptoms or complaints will include a discussion of FIDO-C, where the F is for frequency. All the doctor would have to do in the exam is say, injured worker, you told me that you're anxious, or you said you're, what's the frequency of your depression? Depressed? The patient can explain, depressed every day, doctor. Or the patient might explain, I'm depressed for about 4 days out of a month. That's a big difference. We need to know the information about frequency. The doctors don't put that in their report. Next, I is for intensity. All the doctor would have to do is say, injured worker, you said you're depressed on a, you have to go to the doctor's emergency room in an ambulance that bad. How would you rate the intensity of your depression? Say it's an 11, or they might say I'd rate it about a 2, give or take, depending on the day. Big difference. Whatever the rating of intensity is, we need to see it in the doctor's report. And unfortunately, it's a rare occasion that you'll see a doctor discuss intensity of a symptom. D in FIDO-C is for duration. The doctor can say, injured worker, you said you're depressed. You told me you're depressed every day. What's the duration of your depression when you have that symptom? How long does it last? The injured worker might say 24 hours. Or they might say 1 hour in the morning when I wake up, usually, and then it goes away. That's a big difference. Whatever the information is from the injured worker, we need to see it in the doctor's report, and they just don't put that in for some strange reason. Now, O is for onset. Injured worker, when did you very first remember having that symptom of depression? What's the onset? They could say the day of my injury. They could say when I was 10 years old and I moved away from home to a different state. Or they could say 3 months ago, very first time I ever experienced depression, my cat died that I had for many years and I was so close to. Whatever the injured worker's response is, we need to see it in the report, and the doctors are not putting this information in. C is for course over time. You said you got depressed 2 years ago, first time. In these 2 years, what's the course your depression has taken over time? Did it go away and come back? Did it gradually get worse? Did it gradually get better? What is the course? We need to see that information in the report. Now, it's often difficult in telehealth exams to collect this information. Why? Well, we are doing a tele or remote session here. This is a very similar situation for psychological evaluations and treatment. The doctor will be on one side of the screen. They'll see the patient from about here up, and that's it. So right now, my leg is shaking uncontrollably under the screen. Do you see that? No. Right now, I'm wearing shorts, not pants, to go with my collared shirt. Do you see my shorts? No. The doctors are missing stuff when they do a telehealth exam. My hands, I'm like wringing my hands back and rubbing them together out of nervousness right now in my lap. Do you see that? No. And when a patient, an injured worker, is doing these types of things, maybe dressed inappropriately on the bottom half, the doctors are not picking it up because they're doing telehealth exams. And if a person's leg is shaking uncontrollably, their hands are wringing in their lap, they have tears in their eyes that you can't see because it's done via video screen, the doctors are going to miss significant pieces of information in order to do their job properly. So, how are they doing their job properly? They're not. You can also not see, but right back there, I'm pointing behind my screen, I have 4 family members sitting and going about their business. When I say something out loud that they don't agree with, they're shaking their head. You can't see that, right? You also would not be able, a doctor would not be able to see family members roaming about, which I'm not going to say anything that's going to be um, sensitive if I know my family members are going to be able to hear. I also am going to strongly pick up on their signals in agreement or disagreement with what I'm saying because I can see them in the room. Same thing happens in telehealth exams, and the doctors are not able to pick up on this information because it's not the appropriate situation for a psychological or psychiatric evaluation. Those are some of the major pitfalls in the area of collecting historical symptom and complaint data for a doctor's evaluation and report. In the area of a mental status exam, there's also significant pitfalls, which I'll explain. But first, let me discuss for a brief moment what a mental status examination is. This is about a 15 to 30-minute portion of a psychological evaluation. Every psych doctor knows how to do a mental status examination, and they all know that it is required. For the purposes of your knowledge, during those 15 to 30 minutes, a psych doctor's job is to observe mood, memory, concentration, insight, and judgment. The injured worker's mood, memory, concentration, insight, and judgment. They make their observations only. It's no more, what are your complaints? Tell me about this, tell me about that. It's only what the doctor observes of the injured worker. Now, what do you think? Can a psych doctor observe an injured worker's memory? Say yes, they can. All they have to do are very simple and quick tasks of memory. Ask the injured worker, what is the name of the street that you grew up on as a child? What is the name of your first grade teacher? Uh, can you recite for me these numbers that I say out loud? 20, 30, 19, 17? Can you say those backward? Those are tasks of memory. And the injured worker's response, the responses should be included in the doctor's report. And they strange reason. Those, if they put the information in, then we would be able to read what the actual observations made by the physician are. Instead, what I read in a mental status exam sound like this. The patient presented as depressed and dysphoric. Their memory was intact. The patient had concentration that was fair. Their insight and judgment were restricted. That's it. That's all I ever read. And unfortunately, intact, fair, restricted, those terms are summary conclusions. They're by no stretch of the imagination observations. And that's observations is the only thing that a mental status examination is intended. So we have to send our attorneys in to depose the doctor and say, where is the observational data in your mental status examination section? Also, look for and be concerned with how did the doctor conduct this mental status exam via telemedicine? Did they just ask these questions out loud? Did they use a form? Did they not do a mental status exam at all? Were there any connection issues or glitching? I had to log into this session about an hour to 30 minutes prior today so that we can get set up and do the testing of the video and the sound and the camera and know how to click and and I had to log out at some point. And when an injured worker has to do these things, especially if they're not familiar with FaceTiming or Zooming or using Google Teams, whatever platform, that can possibly cause irritability, anger, frustration in the moment. Those are emotions that the doctor might pick up on and say, oh, the injured worker seemed very irritable and angry. They lost focus. Well, is that because of the psychological problem and emotional disturbance, or is it because they were asked to do a telehealth exam and they're not familiar at all with this type of remote platform? Could be both, could be one or the other. The fact of the matter is, we don't know, and the doctor will not know. Next question for us all. What psychological tests do you see discussed in psych reports that you read? Again, the QR code's in the top of the screen if you need that at this point. Thank you for those of you participating. Let's scroll down here to see if we have any takers on the Wechsler, the MCMI. It looks like Beck depression inventory definitely is seen in psych reports, as well as the Epworth, the MMPI. Great, thank you all for responding. And briefly, I'll explain. I also see in the reviews that I've done over 25 years of psych reports written by other psych doctors, the Beck depression inventory, the Beck anxiety inventory, the Epworth, the MMPI. Sometimes on a rare occasion, I'll see the PTSD checklist and some of these others listed on the screen. I also see the Milan Clinical Multi-Axial Inventory called the MCMI quite often. And the MMPI listed at the top is the #1 gold standard psychological test in all psychological test batteries. Stated another way, the doctors must use the MMPI. If they don't, it's a red flag. And something should be done. Some line of questioning should be thrown at the doctor if they do not use the MMPI or some similar test. Why is the MMPI considered the gold standard? Because one, it has validity scales. Two, it's the oldest psychological test used for medical legal evaluations, and it is the most widely researched psychological test in all of psychological literature and research. So for over 75 years, the MMPI has existed. There are various versions. I put MMPI 2 on the middle of the screen here because that is the most widely used version as far as I've seen. It was published, this is the version published in 1989. There is an MMPI 3 that was published in December 2020. Some doctors are using that, but only a handful. Now, the biggest question and concern in my eyes with regard to psychological testing done via telemedicine is how in the world did the doctor administer psychological test through a video screen? So I ask that question, and it's so concerning to me because I know and am quite familiar with many of these tests. They come in written form. The MMPI-2, for example, is a true or false answer sheet, and then there's a question booklet. There are 567 true or false questions, and there's an answer sheet to bubble in. So how do you do that through a video screen? Is the doctor reading every question out loud, 567 of them? That's a big no-no. Is there an interpreter involved? Another person on the screen? And are they reading the questions out loud? Did the doctor mail the test to the patient to take it home? Did the doctor send a test proctor to the patient's home to supervise the testing and give them the test booklet and answer sheet? No one knows in any of these reports because the doctors don't state it in their report. All they do is state, I did a telehealth exam and I gave psychological tests and here are the results. How did they give the tests? I'm reviewing a report for an attorney who requested a critique and a script of questions to use in deposition. And in this report, the doctor did a telehealth exam. Something I'm working on this morning before our session. I'm going to wrap up my review and critique and written analysis after today's session. This doctor did say, I did an exam, what did he say? Utilizing telemedicine on April 22nd, 2025. And this doctor also stated in this 20-page report, they stated on page 13, psychological testing. And they gave a list of 8 tests they gave, none of which were the MMPI. They did give an MCMI-3, which is a similar test to the MMPI. And they stated about the MCMI-3, his MCMI-3 profile is attached to the end of this report. There's no profile attached. Last page is page 20. It has the doctor's signature. They also state MCMI disclosure scale at BR 75. I know, because I'm familiar with this test, that a score of 75 on the disclosure scale is above the cutoff, according to the test manual, and the test research in all of the psychological literature says that score means the person is attempting to simulate their symptoms or faking their symptoms. I read on, and the debasement scale at BR 76. I know 76 on the debasement scale is above the cutoff, and the psychological literature says that score means the person is being secretive and trying to hide something. And the doctor, I read on, says the patient's scores may be somewhat exaggerated. And then the doctor on the very next page gives 4 psychological diagnoses: generalized anxiety disorder, post-traumatic stress disorder, depression, and an occupational problem. The doctor said nothing about the patient's scores showing that they were faking their symptoms or how they took that into consideration. And even worse, the doctor said nothing in this report, all 20 pages I read 3 times, nothing, no mention about how they administered the test. How do you give an MCMI through a video screen? How was it done? We don't know. I also know and can tell you all that these tests come with manuals. They tell the doctor how to give the test, who to give it to, how to score it, what the scores mean, and everything in between. For example, The MMPI-2 test manual is approximately 70 pages long. It's lengthy. The doctors have to know this stuff. It's a very complex test. The manual in 2 areas says, do not give this test to be taken at home. Do not read the questions out loud to the test taker, as that will introduce bias and taint the results of the test. So if you don't give it at home, you don't read the questions out loud, and then the test also says this test must be given under supervised conditions with adequate lighting and ventilation. How can the doctor determine that there's adequate lighting, adequate ventilation, and that the test is supervised if the test was taken at home or done via video screen? They can't. So the scores and the results would be tainted and not usable at all. And then the doctors are submitting a bill for psychological testing. In this case of the report I'm reading, the bill is on the back, it is attached, and the bill charges $1,100 for psychological testing services. And then it charged $4,030 for the report. That's an expensive report for something that is not usable because the doctor chose to do telemedicine. So these are just some of the pitfalls. There are so many more to be able to explain, and nuances embedded in psych reports that need to be picked up on. That keeps me busy and challenged, and I love doing. And this brings us to our next slide. How did the patient complete the test, right? These are just a few of the questions that I've already explained, and some others for consideration. I'm going to back up one slide and pay special attention and spotlight on item number 5, standards in the community of psychology and psychiatry. This is a phrase that I offer to you all to use at your discretion. I love to recommend this phrase is used in a line of questioning when an attorney goes in to depose a psych doctor. Ask questions of the doctor that begins with, "Doctor, do you agree with the standards in the community of psychology and psychiatry that," and then follow it up with whatever's necessary. Example, "Doctor, do you agree with the standards in the community of psychology and psychiatry that the MMPI is the #1 gold standard test of all psychological test batteries?" The doctor is not going to disagree with the standards of their own community and colleagues of their profession. And you can use that phrase, your attorneys can use that phrase when warranted, attached to any question that follows. And I've mentioned all along that as part of my work, and one of the hats that I wear at Good Mood Legal is reviewing and critiquing psych reports when it's needed or necessary. And I often find that those reports are an added resource or tool for claims examiners, employers, attorneys to use when there's a high exposure psych claim, perhaps, when a doctor does a telemedicine exam, or just something doesn't sit right with the doctor's methods and diagnosis, and something needs to be done to help, as a resource to help the parties fully understand the contents of the doctor's psych report and some of the major red flags that exist in those reports. This slide, I offer some rules and tips for those of you who are either attorneys on the call or are working with attorneys to challenge or rebut psych claims, especially those that use telemedicine methodology. You can take and consider these rules and tips for cross-examining psych doctors and rebutting the psych reports or the claims, because in 25 years of reading psych reports, the most concerning finding that I've had is that the doctors are not correctly diagnosing the injured worker. And when a doctor incorrectly diagnoses because they want to be quick about the evaluation, maybe there's another reason where they incorrectly diagnose, they're just not collecting enough data or evidence to appropriately arrive at a proper or correct diagnosis. So they just give a diagnosis that might be not correct for the injured worker. There are ramifications and implications for that when that happens. One, which is most concerning in my eyes, is the injured worker may not be getting the appropriate treatment. Let's say they're given a major depressive disorder, but they really have a generalized anxiety disorder. Incorrect diagnosis given, they're going to get treated for a major depressive disorder. And work comp system is going to pay for that. When in fact, the injured worker might be most appropriately diagnosed with a generalized anxiety disorder and need treatment that is specific to a generalized anxiety disorder. So it's important, so important to read these reports, fully understand the doctor's diagnosis and the nuances of their methods used to collect the diagnosis. Telemedicine is a method, one of the methods used for doctors to do evaluations. It's an inappropriate method because there are too many risks involved for them to, and often leads to incorrect diagnoses being made. That's a mouthful. I know I offered a wealth of information and for you to consider. I do have time and open it up for any questions that you might want to put in the chat or otherwise. And I do thoroughly appreciate you all listening in. I enjoy speaking and delivering information related to psych claims and psych reports. And the telemedicine topic and the pitfalls associated with telemedicine evaluations in psych is especially interesting for me to be able to talk about. So thank you. Thank you all for being here. And here I'll throw up my contact information. If you have questions that you might walk away with and consider as you let this information marinate, feel free to contact me at your leisure.
Okay, well, we have a comment here, but there's no question that I can tell. It's just MMPI. So I don't know if that
Yeah,
means
the
something to
comment.
you.
Yeah, sure. MMPI is the test I was speaking about, the #1 gold standard test of psychological test batteries. And so Ellery may have been responding to the question about which psychological test do you most often see in psych reports?
Yes, and we have another one that says PTSD, and I think that is also a reply to one of your questions.
Right.
Well, I'm going to give people an opportunity to write some questions down so that
Yeah.
we'd love for them to get their questions. So I'm going to do a little bit of business before. So I just want to remind everybody that this webinar is worth 1 CEU credit today. You should be receiving it within 2 hours. When you get the email, there will be a blue box that says My Certificate. You click that to download your certificate, and that'll pop up. We have some outstanding webinars following this webinar. Later on today, we have one on orthopedics, the cutting edge of orthopedic treatments and surgery. That's at 2 o'clock. In addition to that, this week we have one on upper limb prosthetics. We have Medicare set-asides coming up, apportionment, and how the applicant could get a rating of 100%. That'll be very interesting to see because the difference between 100% and 99% sometimes could be the difference between $1 million, $2 million. So I think we want to make sure we watch that. And outside of that, I think that's all the business I have. You just want to check the MacroPro website in order to see what our webinars we have upcoming. We have 14 total for the month of June because we're trying to help people catch up before the state mandatory requirement for recording your hours, July 1st. All right. Any other new questions? I didn't see any new questions come through, Doctor. So I want to thank you, and I want to thank April very much for joining us today. Would you, either of you, like to say something before we close?
Well, I do see one question. Do you have any thoughts to share on virtual evaluation of PTSD specifically? So my thought on that is that today I discussed using the example of major depressive disorder. I could very well have interchanged that with PTSD, and all of the information discussed today applies. You want to look for Fido C about the symptoms discussed in the doctor's report. You want to look for telemedicine methods used for a mental status exam, and also how did the doctor do the psychological testing virtually. And then you want to also look at the testing results, the testing scores, whether they use the MMPI. And there's so much more that we could talk about probably for 5 hours, but we're limited to the hour. So those are just some quick tips to try to pick up on for yourself. And I
Uh,
appreciate the questions.
I think, do you see the comment there from Jim about body language, pointing out that you can see the body language. You can't see the body language through a camera, which I think is probably very, very true. You can see part of it, but I think people could be controlled a lot like your leg analogy earlier today.
Mhm.
And I see that lots of people are saying thank you for a great presentation. And we do thank you so much, Doctor, for joining us this time and all of the other times that you have in the past. Until
Yeah.
today at 2 o'clock, we will see you then. Bye bye now, everybody.
Have a great day.